on. Hello, everybody. Welcome to another episode of Find Your Model Health, the official podcast for those looking to optimize their long-term health and weight goals and understand how their body really works. I'm your host. I'm Chemaines Linney. I am integrative health practitioner, certified iridologist, nutritional therapist, and fitness specialist. I'm very happy to have you all with me for another piece of your day. I really do appreciate it. I know there's a lot of podcasts out there that you could listen to, but you choose to listen to mine. So thank you. So before I introduce our very awesome guest, and don't blush, Keith, I want to remind you that the information in these podcast episodes is for informational purposes only and should not be taken as medical advice. Please consult your health practitioner before making any lifestyle changes, because neither me or Keith are doctors and we don't claim to be. So today I have the wonderful Keith Littlewood on to discuss thyroid and a couple of other topics with us. If you haven't heard of Keith Littlewood, also known as Tomo Littlewood, over on Instagram, you'll find him there under that name. He is a hormone, endocrine, and I would add, shall we say, pollution specialist to that. He has a bachelor's and master's in thyroid and hormones, and Keith, you can correct me if I'm wrong, but he is just one of the most amazing brains I've come across when it comes to thyroid. So Keith, thank you for coming on and giving me a piece of your day.
Thanks for having me. My first degree was in fitness and health, so not associated with endocrinology, but my postgrad and masters were in endocrinology. So yeah, pretty much right there. I guess pollution is just getting thrown in there because that's the sort of things we're starting to look at about how they affect steroid hormones and thyroid hormones in particular. So you just become wiser about what you're going to assess in the lab, about what might elicit a response that becomes problematic to the hormones in the long run.
So just kind of stepping back a little bit, because most people won't know you here where I am, most of my listeners. Your background first started in the army, and then you decided that wasn't for you. How did you go from there into health and fitness and then into hormones to where you are now?
Yeah, so I mean, I went into the army because I literally didn't know what I wanted to do. And then I knew quite early on that I didn't like being told what to do. So that was never going to be something that was going to be long term. And I think it was just, I was floating around for a bit. I did some summer camp work at a leisure centre, and somebody ended up being sick in the gym, and they said, can you take an induction? I didn't have a clue what I was doing. So it's quite good. Went into the fitness centre, moved to London, became a personal trainer, had a gym, left the gym because I didn't like managing people, and then kind of got into more the clinical side of things, got really into rehab, therapy kind of stuff that you do as well, and was in rehab and pain work for some time. At the same time, I kind of started, looking at functional medicine, and nutrition at some level. And I just I was introduced to the work of Ray Peat, and Ray Peat's ideas kind of opened me up to many other scientists' work, which really kind of expanded my thinking around biology. And really that was a catalyst for me to go back to uni and go, well, actually what he was talking about, does it make sense? And how can I kind of challenge my own bias? And so it was really there. Then I was trying to make a distinction whether I was going to stay in kind of rehab work and conditioning work, or was I going to go kind of back into biology? And after I got my master's, it was quite clear that actually this could be something that I could make a living out of. And I got into coaching people, which I had been doing for a number of years anyway. But it was specifically around energy, digestion, sleep, fertility, mood, these kind of things that a lot of people were faced with on a daily basis. And so then I was living abroad, now back in the UK, where I'm doing a PhD up at Reading, which is down the road, and kind of just trying to make some sense of what you see in research, how things are treated medically, whether they make sense. Are there lots of factors that perhaps are not glossed over, but perhaps misunderstood, because the feedback mechanisms that we have from a hormone perspective might be substantially mediated by what someone might inherit, damage from their parents, not just damage, positive things as well that can occur, but also what's going on in the environment, that can actually mask those feedback loops. So obviously that understanding stress and other aspects of life, whether it's from pollution or physical, chemical, emotional stress, all of these things that can suppress someone's physiology. And ultimately, we tend to see people all the time that have key things, and I kind of hit it on the head there, digestion, sleep, libido, mood, fertility. These are all things that there are some things that, where cases are substantially increasing. And even at some of the suggestions around fertility rates in certain countries that look like they're in decline. There might be some very robust reasons why that are happening, but it becomes infinitely harder to measure sometimes because there's so many things to consider.
Yeah, you clearly have a hunger to learn and understand more and fill in the gaps that are not being filled in by mainstream medicine. And I'd even go as far as your area, Georgie's, Danny's, Ray Peat's. It shouldn't be more specialized, but it is. It's not part of the mainstream, although it's growing. So there's a lot there that's missed by mainstream and then misunderstood by people who are following you guys. If even when I had Georgie on recently, as we mentioned, and Georgie, of course, with his accent, and he speaks so fast. I got a lot of messages saying, what is he saying here? He speaks too fast. I don't understand him. And I don't think it's necessarily the speed, but the wording. People don't understand it. So there's a mismatch there, and hopefully we can help to close that gap over the next couple of years. So was it Ray that really kind of helped to open that Pandora's box for you, of where you're like, there's more to this, I need to know more?
Yeah, I mean, I was looking at functional medicine, and I did go down a path of doing hundreds of tests and, looking at, never used prescribing, but, recommending lots of different supplements. And I got to a point with that where I just thought, is this the right thing to do? And sure, you can reduce, you can compartmentalize, to a stool test for gut function, or amino acids or neurotransmitters and that. And I think it was Ray's work, very kind of small but beautifully written, and kind of very much enlightening some of his books. And particularly, it was key that thyroid was one of the key drivers of function, organization, and how we are supposed to manage ourselves as complex, beings as such. And it was clear that thyroid was implicated. When you lose thyroid function, that's where you see most of the systems within physiology break down. They tend to be more catastrophic during gestation. This is why we do tend to see some increasing issues, perhaps around ADHD, or kind of advancing or brought forward perhaps states around dementia and Alzheimer's, as an example. But if we don't get thyroid right, we can see these systems start to break down. We can see increased cholesterol. We can see poor glucose signaling. We can see mitochondrial cytopathies and mitochondrial damage at large. Fatty liver and reduced liver function, reduced brain transmission, neurological decline. All of these things that would impact, which are mediated by the thyroid. And it was Ray's kind of bias towards thyroid that got me interested, and perhaps trying to get a better grasp on what's going on at the supramolecular level, within blood tests, and also at the molecular level, and understanding what receptors are doing. Does the mRNA, is that important from a gene perspective? We know that genes don't drive disease as such, but they can be implicated in certain genomic level issues where genes are being transcribed. But that's just one aspect of function. We can see many non-genomic things happening. We can see things that, even heritable traits that we can inherit are not always mediated by genes alone. So it was kind of that work and his ideas and his suggestions that, yeah, the receptor is quite an interesting thing, but it's not the most important thing. And I really wanted to get a better grasp of these they're termed different disciplines about understanding genes and mRNA, and say, serum values of thyroid hormones, but essentially they're the same system. But medicine tends to break stuff down. We get specialists, we get various isms and schisms that kind of, fragment human biology. And this is where we get all these different opinions and different forms of training of expertise, which isn't necessarily a bad thing. But then we're left with it's either my way or the highway. And you see that with the ketogenic low carb crowd at the moment, for example. It's like missing a basic tenet of physiology is why is glucose signaling lost? Just because you take glucose away, are you curing type 2 diabetes? No, because these people then try and eat carbs again, and their response based upon what they understand is haywire. But then when you understand that these blood sugar levels are very kind of wayward and different depending on different foods, and depending on how much work you have done to repair that damage, this is where we kind of get lost on I say we, but when you break down into these various tribalisms within nutrition and biology, this is where I think we do the public at large a disservice, because there's so many different points of view and opinions. And I think being able to I'm not saying I'm capable of doing this, is taking all of it in and trying to give it to people in trying to understand perhaps what is the most optimal thing, rather than just the best short-term approach. Does that make sense?
Unfortunately, there's a huge financial aspect to all these different dietary recommendations without understanding the biochemistry or metabolic aspect of it. And brings to mind, I used to have a client. In the end, we parted ways. She was so convinced that keto was the way for her. And she had a Dutch test done. And I kept saying to her, no, this is destroying your thyroid. You have hypothyroidism. All her metabolic functions had slowed down, but she refused to accept the fact that she needed some sort of glucose in her diet. And in the end, we just parted ways. But it wasn't that it was her fault. It's more so the message that is constantly being played over YouTube and Instagram and Facebook, and dare I say, she was almost brainwashed, and so not her fault. But yeah, you kind of, as you're speaking there, reminded me of what Broda Barnes said in his book, that all undiagnosed conditions can be related back to hypothyroidism. Would you agree with that statement?
Yeah, I think a considerable component of human health is whether it's the gastrointestinal system, reduced motility, whether it's kind of neurological decline, whereas it's cognition, libido, cholesterol, blood pressure, blood glucose levels, all of these things, and even certain cancer, which essentially is mainly a metabolic disease. When we're getting changes to the loss of oxidative phosphorylation and the ability to use carbohydrates and fatty acids as a fuel. I think a lot of people either go down the route of, like, particularly the keto crowd, it's like all fats. Some people suggest that, within the Randall cycle or the glucose fatty acid cycle, that you would do better to just burn carbohydrates all the time. But I think what's really important to understand is that there should be a flux between these systems. Even in the brain uses a vast amounts of glucose, but it's quite clear that astrocytes, which have a huge demand for thyroid hormone, they're prone to oxidizing fatty acids. And it's these problems that when they break down, particularly in the aging structures of the brain, is the inability to utilize glucose. And if you're constantly burning fatty acids as a fuel all the time, if you're constantly getting issues in the liver where there's decreased fatty acid oxidation, and there's an accumulation of triglycerides because all the carbohydrates that you're intaking, you can't utilize them. This is where the problems occur. So low thyroid function does become a systemic issue. It's not like, if you had, say, a reduced, there are other hormones that will have key problems with thyroid, because it's so organizational, because it synergizes with many other hormones, and is the gatekeeper for our sex hormones, for example, progesterone, testosterone, and how estradiol interacts with the body. It does become quite problematic. And also, because there's such a burden from environmental pollutants, this is where the thyroid can become an issue. And this is where we see aspects like estrogen dominance, which also can come from xenoestrogens, and these type of pollutants can cause problems as well. So I think it hits the nail on the head. But analyzing and perhaps diagnosing that becomes problematic because of the graying of analyzing thyroid physiology by the standard, what a perceived gold standard test in the medical industry, which is TSH and T4, which can be a complete waste of time in some cases.
I do want to discuss that, but I had heard Ray, for those of you listening who don't know who Ray is, Dr. Ray Peat. I had heard him mention in one of his conversations that he believed that even respiratory illnesses and viruses were in a big part driven by hypothyroidism and how the thyroid affects the gastrointestinal tract. That alters the microbiome, and then that has a, I suppose, back upstream effect on the respiratory system.
Yeah, and within one of the factors that's implicated in lung disease, particularly lung cancer, is a thyroid transcription factor, which is certainly it's a gene that's associated with thyroid function, and this is significantly upregulated within the lung tissue. Now, at the moment, whether that's a product of, say, it being there because the tissue has become aberrant and it's trying to get some organization there, because it's at the moment it's just a correlation, it's not causative. So we can see various genes that are associated with thyroid function, and also plus some of the metabolic effects which aren't mediated by the genes, as I mentioned, are certainly regulated by T3. So when you don't have adequate T3 instructions, and bear in mind that the lungs are one of the key areas where serotonin is metabolized. If you have a high serotonin state, which is associated with stress, you will often get low thyroid, or the low thyroid might be driving the accumulation of serotonin, or perhaps interacting with stressors in that way that suppress it. From a viral perspective, even if we just take into COVID as a thought process, whatever your views on it, and I have some very strong views about that, which I won't
Probably
go too much
the same.
Probably the same, is that, and there's quite a few papers, and what they've shown is that people with low T3, and this is not just associated with COVID as an example, but non-thyroidal illness syndrome is one way to look at it. But the lower your T3, whether it's in COVID or whether you have a very severe illness, your likelihood for death or kind of long hospitalization is severely increased. Now, there are plenty of papers that suggest that low thyroid function was associated with a worse outcome with COVID. There are also papers that show that with progesterone as well, because progesterone protects the lungs. Thyroid protects the lungs. And again, because they are such high metabolic structures, any of the organs are really to a degree, to the extent that you lose optimal functioning of the metabolism of those structures, you are more likely to succumb to a viral infection. Because bearing in mind, most people get sick, their immune system is suppressed, or they're missing something that's stopping to express their health. Generally, as a rule of thumb, the healthier you are, the less sickly you will get. You will either get sick in a different kind of way than people that have some comorbidity, whether it's like, something like fatty liver, or, diabetes, or hypercholesterolemia. And again, we can come back to all of those being thyroid linked.
I'm glad you brought that up. It was unexpected, but I'm glad you brought it up, because during the whole COVID fiasco, there were a lot of what we would perceive as healthy people, slim people who exercised a lot, getting very sick and even passing away. And there was a lot of comments being circulated. Well, I thought it was only people with comorbidities or obesity that we could visually see were unhealthy that would have the worst outcomes here. But yet so-and-so down the road, they dropped dead and they were perfectly healthy. Just because somebody looks healthy does not mean that internally they are healthy. You've no idea what is going on with the metabolic system or the hormones or the gastrointestinal tract.
Yeah, and you can look at it. So if you look at perhaps what you might term advanced elite athletes, you could be a triathlete and still be relatively unhealthy. You could be a bodybuilder and still be unhealthy. Why? Because some people who go into exercise and have an addictive personality will suppress thyroid function, and their TSH will be really low. So a doctor would look at that, and this is, just digressing slightly, would go, your TSH levels are fine, actually. They look really, really normal. But to the extent that you over-exercise, and bear in mind that some people that over-exercise will be cold, they will exercise on a daily basis just to bring their body temperature back up so they feel a little bit better. And these are the people that go, I don't like to stop exercising because I feel like crap when I do.
Mhm.
And it's stopping exercise and seeing how you feel. Because if your body takes a shunt down, it's a good sign you're trying to just bump up your metabolism by getting your body warm each time.
Mm.
And the body can be stiffer, and a lot of the blood tests would appear to be completely normal. That's why you had some bodybuilders that dropped dead. I think there's a well-known guy, Doug Brignoli, as an example.
Yeah, I was reading about him this morning. He said,
Right, okay.
you can use me as a prime example. If I drop dead, then we'll know so and so is dangerous. If I don't, blah, blah, blah. And he did drop dead.
Yeah, not even just to fit people. There are supposedly some of the more intelligent people of us human beings who are using thought process that didn't make sense. Nicholas Nassim Taleb, who's supposed to be a philosopher, took a picture of himself wearing goggles and two face masks, saying, "I'm really protected here." But one of his books was about being understanding robustness and randomness within the markets, but he was extending it to physiology as well. And I just think this kind of thinking was so backward and myopic about not just what was going on, but people weren't looking at key aspects of function like progesterone and thyroid function, and they were going for more kind of fear-based stuff about what it could do, negating the fact that human physiology is the most protective thing to keep at its best working order. And this is what thyroid hormone does. It keeps physiology working at its best working order. And as I said, that can be systemic across the body.
Yeah, instead of focusing on what can we do to support metabolism so that the body can fend for itself.
Mhm.
So I do want to just pause for a second. For those of you that are completely unsure as to what we're talking about, we are talking about thyroid health and specifically low thyroid function and how it influences the metabolism and all the metabolic systems. So, your thyroid being a small gland here at the bottom of your neck that is basically master regulator for pretty much all of your metabolic functions and systems, including DNA expression and genetics. But Keith, I want to ask you because I don't know how much you know about the whole health system in Canada. Here, I've been here for 11 years, as I mentioned, been in the health industry since 2008. So I've had a lot of one-to-ones with people and heard a lot of different stories. And it's my perception now that in the people I work with, at least, approximately 80% of them have low thyroid function. And a lot of that I would correlate to high stress functioning lives, minds, and bodies. Um, it's quite hard to get thyroid support here in Canada. Unlike the States, so we can't access thyroid hormone. There's a lot we can't get here. But I'm curious as to your opinion. Why do you think, and we can include the research you've done on pollutants and environmental toxins here, why do you think hypothyroidism and low thyroid function is so prevalent nowadays?
Well, I think it's the if you were to speak to some experts, that they would say it's because we have better detection strategies, which is akin to saying we have a bigger telescope, we're going to see more stars. Well, if you keep expanding assessment in that way, you're always going to find it. With thyroid, I think it's slightly different. I think that there are more people these days that are inheriting low thyroid traits from their parents. I think the environment, which is actively suppressing thyroid hormone, there are many chemicals even within the house that seem to have thyroid suppressing effect. Now, the common things are in house dust that they found, like bisphenols in plastics. They found brominated flame retardants, which are particularly problematic because they have a very similar structure to thyroid hormones. And you throw in everything else. There might be like our bias towards nutrition. We put stress in there. I think decreased sleep physiology or decreased restorative sleep. Perhaps you could throw light exposure in there as well, vitamin D loss or deficiency, even red light exposure, all of these things that would naturally support thyroid physiology. I mean, you only have to go back not so long ago when there were kind of large parts of Africa, even in Middle America, where, and particularly in China, where it had the largest case of pregnancy, which was basically what happens to you when you don't have good thyroid physiology when the mother is pregnant, as an example, is that you will get this kind of very aberrant damage to the central nervous system, leading to cretinism. And even with, and low thyroid states as well, Africa was a particular thing because there wasn't much iodine around. They weren't close to the sea where there was lots of seafood. And that's historically why you got iodized sea salt, which was, brought in particularly in North America, is that there are many factors from geography through to the current thinking, which is perhaps, and, if you look at most statistics, people tend to say anywhere from 1 to 5%. Some people will say 5 to 10%, and I think some research have said around up to 20%. And I think that's probably hitting the figure where it should be, at least 20%. So if you're saying that there was definitely 5%, you can say that there's quite a lot more, because defining someone's thyroid status just by looking at TSH and T4 will lead to more people being functionally hypothyroid. You will get subclinical hypothyroidism, which is the thyroid hormones are normal, but the TSH is elevated. That's still not taken on board as being something that's worthy of treating. And the problem is that when they've treated people in those studies with just levothyroxine, there's not been some of the changes that you would see. They might, and it depends which study you look at. And there's quite a few studies that either support or don't support treating subclinical hypothyroidism. But if you've got people that aren't converting T4 to T3 very well because the liver's not functioning very well, as an example, is that T4 is not going to be the right intervention to treat these people with low thyroid and particularly subclinical hypothyroidism. So I think all of these things get conspiring, whether you're an over-exerciser, whether you're somebody who's not sleeping that well, whether you have gastrointestinal issues and you're not absorbing thyroid particularly well, whether you're kind of under stress, whether you're exposed to lots of these chemicals, all of these things can converge to cause the problems of low thyroid function.
And we would include high adrenaline and low progesterone here, because progesterone being pro-metabolic, and if we have low progesterone, then we have higher estrogen, which is anti-metabolic, and there's a lot to be considered when it comes to why is your thyroid under functioning or struggling.
Yes, and a high estradiol will on its own suppress thyroid function. It will stop T4 binding to particular carrier proteins. It will support the suppression of thyroid hormone at the gland. Although there are only associational studies that the findings of uterine fibroids and thyroid nodules, there are associations there. There's nothing causative, but if we take from the point that we know that estradiol, which is a known carcinogen, does promote uterine fibroids, does promote endometriosis, does promote breast cancer. It synergizes with progestins, which are the synthetic forms, and that's where the muddying of the waters comes in with particularly breast cancer issues, is that these things will suppress thyroid function. In a healthy system, this is where TSH can be useful. TSH rising is a normal response to decreased thyroid hormone production. But to the extent you have someone who's stressed, which is going to suppress TSH production, but still having high levels of estradiol and low progesterone, this is where problems can occur. So it's perhaps understanding this is why symptoms can be very, very useful. It's no good going to see someone and say your blood tests are absolutely fine. And I've seen this with clients in Canada, in Australia in particular, where the clinician is just totally myopic to looking at thyroid in any shape or form. And also the insurance companies are in with this, that they'll only look at TSH and T4. And you could argue from a conspiratorial, approach is that one of the things that's worth considering is statin medication industry is worth, this was 10, 15 years ago when I was first again, was worth $30 billion a year. Now, if you're just throwing out statins just to people, just to lower their cholesterol, just because the cholesterol is out of range, and there's some argument about what is the exact decent range for cholesterol to be at, is that you're just suppressing some form of function. We know that cholesterol rises when there's ongoing inflammation. Usually when there's high levels of C-reactive protein, cholesterol levels are higher. when TSH is increasing, cholesterol levels are high. TSH causes problems by regulating how much inflammation goes on, because TSH in itself is associated with inflammatory markers that lead to fibrosis and other issues. And this is where we can see fibrosis in the reproductive tissues, within the thyroid, within the liver, and all of these things that are associated with low thyroid function, which can be mediated by an excess of estradiol. Excuse me.
That's okay. You mentioned the TSH, and in Canada, generally, that's the sole test that's done for thyroid. Once in a while, a doctor will test. I'll usually see total T4. Of course, I look at, like you said, the C-reactive protein. I'm looking at the cholesterol, the liver enzymes, but the doctors are sending people away. Everything looks normal, but nothing of what they're experiencing or telling me is normal at all. So I heard you mentioned before, and I really want my clients to hear this from somebody else. I think they get to the stage where they're like, okay, we'd like a different opinion, a second opinion. You had mentioned that testing TSH alone was useless. Now, I agree with that. And even when I see clients with a TSH of 1 or lower, but all their markers are telling me like something's going on here, this is not correct. Why is TSH alone useless?
Because TSH is its net value as a hormone is to support thyroid hormone production. Now, T3 is a product of how much TSH and T4 is being produced. So, depending on who you talk to, I genuinely think, and it's not just based upon my thought process, there are many other people that kind of have this idea that T3 should be in the upper 20 percentile of the range. Most people you'll see when they have normal TSH and T4 values, if the T3 is lower end of the range, then you can start to suspect low thyroid function. And the TSH, I think it's great. In a normal healthy system, if you're taking adequate amounts of thyroid hormone, you will see TSH suppression. And TSH suppression isn't necessarily a bad thing. I talked about elevations of TSH as an example. They're associated with fibrosis, interleukin production. They cause general nasty changes to tissues over time. What TSH does, and when it reacts, also when it binds to the TSH receptor, having high levels of TSH is not a good thing to do. And there are plenty of studies that support the idea that even around about 2, it's associated with inflammation and loss of insulin signaling, glucose signaling as well. And so having it towards the lower end is great, but at the same time, you could have that because you're running around stress, producing loads of adrenaline and cortisol. So having that TSH value there on its own then is not indicative of anything. It's a bit like looking at serum iron values and going, oh, we might think you're anemic, but the serum iron value on its own doesn't mean anything at all. So it's just a way of having an algorithm to treat people and tick boxes in the end. And then you can start to supply single sources of medication. Oh, look, your glucose signaling, your glucose values are high. Here's metformin. Okay, look, your cholesterol levels are high. Here's a statin. Your blood pressure's high. Here's a blood pressure medication or antihypertensive to treat that. And if you go for those single source actions of medication, you're never going to get to the hierarchy of the problem. And disordered thyroid signaling could be one of the drivers behind most of these disease states.
Do you think it would be more beneficial for someone if they could to test reverse T3 and also prolactin, progesterone to get a better idea? Is there a thyroid issue here?
I used to think reverse T3 had a really good value. I think reverse T3 will go up and down all the time. Bearing in mind it's a deiodination to basically reduce T4 and T3 to a less metabolic form. Now T4 is described as not as being a pre-hormone light or the less metabolically active than T3, but T4 is actually quite a potent hormone on its own. So I think reverse T3 could be okay, but don't get too wrapped up in it because it could be high and low throughout the day depending on what's going on. It's there to control what's going on in the cell. I think prolactin can be useful because it can be a sign of what's going on from an estrogen perspective for sure. I just think genuinely looking at the T3, whether it's free or total or both can give an indication. 9 times out of 10, total thyroid hormone values correlate quite well with free thyroid values. And if you see a suppression in total, sometimes you will see a suppression with free forms as well. So I think all of those can have more diagnostic bang for your buck, as it were, to give you a better all overall picture. I mean, you can still be hypothyroid and not have increased cholesterol production, as an example. Not all of these things tick the boxes. You don't have constipation, increased cholesterol, full glucose, metabolic syndrome, all of those all at once. There can be a cluster of different things going. And so this is why it pays to listen to the person, which becomes inherently harder these days anyway, right? Because of the time restraints that doctors are under. But literally listening. And this is why I think a lot of freelance people and other clinicians do really well who are outside of the system, because they're generally invested in sitting down and listening to what the problem is and just listening to the story and what's going on, looking at the symptoms, looking at blood tests, looking at other tests can give you a much better picture. So all of those can be beneficial in some way or form. You can look at lactate, values within the blood. That can give you an idea of metabolically what's going on. You can look at liver enzymes. Even the red blood cell indices can give you a good idea, whether it's hemoglobin, hematocrit, mean corpuscular hemoglobin, red cell distribution width. All of these can give you an indication, because they will go varying ways when low thyroid function is happening, because ultimately thyroid controls how many red blood cells you produce.
Mm-hmm. So the next question was very basic question, and I think I know where you're going to start with this, is for someone that wants to start addressing their thyroid health and supporting their thyroid, what should they do? Should they jump straight into supplementation? What about, well, over here we generally only see Synthroid being prescribed. It's very, very rare to see any sort of T3 prescribed here.
Yeah, I'd never recommend anybody jump straight into taking thyroid hormone. There are some caveats for everybody. Understanding what your nutrition's like is a key thing. Looking at various aspects of function, sleep is a big one, digestion, mood, energy throughout the day, healthy responses to stress, how you react under kind of being stressed. All of these things are useful to understand. Now, if you get a good idea of those, you know what your thyroid bloods are doing. Getting a whole gamut of those can be useful. If you don't want to do that, and I understand sometimes testing is both expensive and it comes with various other things about having to go to the system. The Broda Barnes book, which you talked about, always give a really good, very crude but useful test. It's not foolproof by any means, because there can be many other reasons why temperature can be low. But looking at temperature and pulse can give a really good, useful indication about what's going on there. Mm-hmm. I think making sure that you're eating on a regular basis is always going to be key. I think there's a number of things that you can do from a food perspective. There may even be a need for other supplements to be used first of all, because it could be that a female is progesterone deficient or vitamin A deficient, for example. A lot of females like eating organ meats, so getting liver in once a week would help for thyroid hormone conversion, help the liver function more efficiently as well, making sure there's adequate retinol for tissue differentiation, all these other things that go with it. But if there's a lack of progesterone, that can be a key driver of why you're in a semi-hypometabolic state, because your body can't warm itself when there's not enough adequate progesterone. So it becomes a question of it depends. Now, I have no problem with recommending people to look at some of the research and ask themselves whether they need to take thyroid. It's not, I don't think, and I don't care if I'm speaking out of turn here, because the average doctor will say, "Oh, you can't take thyroid hormone; it's really dangerous. It's like it's going to cause you lots of problems." Now, there are some caveats there. If you're at immediate risk of having a heart attack, which most people generally aren't, then you're unlikely to go in and do too many issues to yourself. You can do if there's this immediate risk. But that's why taking thyroid hormone, people should always start with a very, very low dose and consider titrating upwards. You will go hypothyroid and you will know it, because your heart rate will go well over 90, 100 beats a minute, and it will stay there. Now, for people that have relatively fragile hearts, that's why that's not a good idea to do. I'll kind of just throw in a story that someone I was working with many years ago. and they just didn't listen to the dosing strategy that I told them. And they ended up taking a whole bottle of natural desiccated thyroid within a few days, which would usually last most people a month or so. And they were in their 30s, and lo and behold, their heart rate went up to 150 beats a minute and stayed there. And I said, look, don't worry. All you need to do is to stop taking it. There are some other things that we can do to block this action. But at the moment, you don't need to worry too much. Just stop. And lo and behold, dropped like 50%. And then the next day it was back down to normal. So it can be very, very safe. So people just need to be sure that they understand what they're doing. So it can be useful. It's not something I recommend somebody do on their own. I always, there's nothing wrong with experimenting and being in any one with yourself, but just know what you're doing and know that there are certain risks in young, healthy people. That's not too much of a problem. So I think it will always be an it depends answer. So I realize I'm not being succinct with that, but I think there are general points and factors that people need to be aware of.
Well, I think we both agree that starting with the nutrition first and making sure you're sleeping, those are the first things before approaching anything else. You mentioned with dosing thyroid hormone, starting at lower doses and titrating up. Is that both for T4 and T3? I know Ray had mentioned just almost snacking on T3 in small doses across the day.
I kind of have a current bias at the moment, and my bias around T4 is that I'm sure some people do really well on something like a Cyno Plus, but Cynomel becomes a useful kind of thyroid supplement of choice, primarily because some of the issues that seem to be geared around associations between T4 and cancer is that an excess amount of T4 seems to be implicated in factors that are associated with cancer. Now, what I don't want people to do is running away going, oh, T4 causes cancer. It's like, I think when there's low T3 and T3 is not being converted, if there's an abundance of T4 is proangiogenic. So it increases nitric oxide, vascular endothelial growth factor. And this is what we see within cancer, is that their T4 can stimulate that pathway. It's non-genomic, and it binds by something called the integrin receptor. And so these high levels of T4, there's a couple of studies, and they're only associational studies, that suggest that T4 is likely linked with or associated with various types of cancer. And I can't remember if there were something like brain cancer and a couple of other ones. And that might be because the excess of T4 around. Now, I think that's probably linked to a state where people aren't converting T4 to T3 efficiently. And this is why I think using T3 can actually be a lot better for a lot of people. Because if you're not converting T4 to T3, and I'm not saying that most people don't, but there could be a certain amount of people where this is key. So I think using T3 and using the temperature and pulse to analyze that could be quite useful for a lot of people without taking T4. That said, I've seen some people do really well with T4 and T3 combos. So it's just something to consider at the moment. It's just some of the research that I've been looking at from this kind of potential interactions between cancer and T4 being excessive.
Why would someone not be converting adequately? Would it be liver stagnation, selenium deficiency, low carb diets?
Well, selenium's interesting because it's obviously linked to the deiodinase enzymes, and it's the key regulator intracellularly of thyroid hormones. Now, T3 is most abundant within the cells. You get T3 in the serum, but that's not even, it pales into insignificance what you actually find within the cells themselves. So there can be a number of factors. There are a number of chemicals, and again, I think the brominated flame retardants and some of the bisphenols here are implicated in having very structural similarities to the T3 receptor. Now, T3 receptor is being bound, and depending on the forces, the hydrostatic forces, and the conformation of these structures, how they bind within the binding domains. T3 will bind with its cognate receptor, which binds with the thyroid response element and will dictate how genes are activated. The genes aren't the only part here. We have the metabolic effects as well. But if they're just binding and they're not allowing the T3 to do its job, what's still not clear yet is whether it's having a repressive or an activating effect. Because some will act as co-activators and mimic T3, some will act as repressors and block T3. And this can become going on in the cell. It can increase the degradation of thyroid hormones at the liver. And you talked about the liver. I think the idea of what used to be called non-alcoholic fatty liver disease, which is now termed metabolically, I think it's metabolically activated steatic liver disease, MASLD, I think it's called now, as opposed to NFLD, is implicated in the thyroid problem. And what we see here is fibrosis within the liver, reduced fatty acid oxidation, reduced carbohydrate metabolism, and reduced T3 action within the liver itself. So the liver becomes a primary site. And we know the liver is one of the primaries. Basically, T4 could be converted to T3 pretty much anywhere within the body. And that happens all the time. But in the liver, because it's a key regulator of energy, when you have reduced thyroid hormones, particularly T3, you see reduced fatty acid oxidation, you see reduced cholesterol enzyme production, like hydroxymethylglutarate, HMG co-reductase, sorry. And you also see decreased cholesterol receptors. So this is where we get an abundance of cholesterol increasing, which is associated with the metabolic deficiency that you see at the liver. So it becomes a huge problem within the liver and intracellularly, because if these chemicals are binding to specific sites, they could also be reducing the amount of transport that takes place. It could also be affecting the nucleus of the cell and how T3 binds to it. It could be also affecting how much T3 or T4 is being carried within the serum transporters as well. The free values, the total values. So there becomes many complex issues about why T4 isn't being not just converted to T3, but how it's transported as well. And we know within the brain as well that when reduced T3 is occurring, then we don't get as much metabolism within the brain. We get reduced cerebral blood flow. So it doesn't become just a liver issue, skeletal muscle issue. It becomes a brain issue. It becomes everything as well. So this reduced conversion of T4 to T3, along with the transport, the uptake, the binding, becomes a huge problem.
Thank you for elaborating on that, because in Canada, in Alberta at least, the primary prescription for hypothyroidism here is Synthroid, which is T4 only. So friends who are taking the Synthroid, we want to make sure that you're converting, like optimizing all these pathways to support the conversion. Whether or not excess T4 could be problematic, we still want to convert it, otherwise we are not getting the benefits of taking thyroid. So I have a question.
Yeah, my message there was not to scare people about T4. My bias was merely down the lines of that T3 could be more beneficial for some people. So yeah, it's not something I wanted to kind of scaremonger people about just taking T4 for sure. You might find taking T4 to T3 does work better. I have seen some people do really well on levothyroxine. Some people just not even touch the sides. And you can see, looking at their crude charts as an example, is that they're taking 100, 150 micrograms of T4 and their body temperature is still not going much over 36. So that's clear that they're hypothyroid, but the medication isn't working as well as it could be.
Yeah, I have a client on 200 micrograms and another on 250 micrograms, still experiencing the weight gain, the fatigue, cold hands, feet, hair loss, gastrointestinal issues. Even though these are quite high doses of T4, they're obviously not converting. And then the question begs, why are you not converting? So I have a question for you, and this has always interested me. This is a very layman's question, chicken egg kind of question. Which came first, the thyroid dysfunction or the liver dysfunction?
It could go both ways. It's a bit like, you could apply that to literally anything. What came first, the thyroid dysfunction or the sleep dysfunction? Could be both. And it really just does depend. Most people bring to the table a multitude of issues which will kind of have one of those things predominating. So it could be liver dysfunction driving thyroid dysfunction. It could be thyroid dysfunction driving liver dysfunction. And we know that's particularly true. Even if we take into the idea of one of the common things that you see a lot in the health sphere at the moment is that vitamin A is problematic. and particularly saying that you shouldn't consume vitamin A. In fact, you should be depleting your vitamin A store, which kind of ignores the very important point that vitamin A is pro-thyroid, and it's also pro-tissue differentiation. It regulates the health of different tissues by making, just like progesterone, differentiate, just like thyroid does, it differentiates. It makes tissues recognize what they are instead of being problematic. And at the worst case, causing DNA mutations and metabolic issues. So with regards to vitamin A, you can consume too much vitamin A, particularly in the carotenoid form, that would suppress thyroid function because the liver's energy is suppressed, because vitamin A and carotenoids will kind of suppress liver function. But to the extent that your thyroid is already low, a moderate amount of vitamin A could suppress the thyroid conversion of liver function even further. Mm-hmm. So it becoming to be a bit more nuanced about what could be there. Does it make sense that you should be cutting vitamin A out of your diet? Yeah, if you've consumed too much of it, but what is that too much for some person? Someone that's in the sunshine all the time will require a lot more vitamin A. And I've seen this in clients who required 70 to 100,000 IUs of topical vitamin A to get rid of their skin issues in the past. So it becomes, it is a chicken and eggs question. And it's usually the egg or the chicken that predominates, really.
Yeah, my mind tells me that potentially could be thyroid if we're going back to gestation, childhood trauma, stress, adrenaline, then the thyroid, then the liver when you start to get exposed to more junk food, then the liver follows. But I don't know, that it's always like, could it be this, could it be that? Interesting for sure. With vitamin A back in 2019, and I remember specifically I came across a study, and it just, I don't know, God put it across my table, and basically it was showing that 20,000 international units of vitamin A taken 3 times daily, which is quite high, that's 60,000 international units of vitamin A day, was effective at suppressing mycoplasma and inflammatory cells in the reproductive system, specifically the vaginal canal. And I had utilized this on 2 clients, along with some other practices, of course. But that high dose of vitamin A, it seemed to be quite efficacious, where the medications the doctors were prescribing was not working. So I do believe there's potential there with the vitamin A. But like you said, we've been told we should be careful with vitamin A. I remember when I was pregnant, like 12 years ago, coming across an article somewhere how pregnant women should reduce their vitamin A intake because it could be toxic to the fetus. And that included reducing your green tea consumption because you might get a high exposure of vitamin A through that too. So it was quite interesting.
Yeah, I mean, vitamin A toxicity in the form of tetrogeneity, which is basically the excess exposure of vitamin A can be harmful to the fetus. But you have to kind of understand that in the context that quite a few things in excess are harmful to fetuses and physiology at large. So there is a sweet spot for vitamin A, just like there's a sweet spot for vitamin D or vitamin K. All of them have their Paracelsian dose, as it were. The dose will make the poison. And more often than not, I think the people that are talking about this vitamin A in excess just generally don't understand how to look at thyroid function. And to the extent that you are hypothyroid, we'll find that vitamin A is problematic. Even vitamin A from retinol sources can be problematic, but it's more likely that you're accumulating lots of the orange carotenoids first from your squashes, from your oranges, and all of these other things that you could be consuming. Even your green veg as well are very high in the carotenoids as well. So someone that's eating a diet that's high in kind of lots of raw green vegetables is going to be exposed to vast amounts of carotenoids as well. So yeah, I think just understanding what the thyroid's doing can give someone the edge there. And I generally think if you were to look at most people's thyroid function, metabolic rate, you'll probably find that suppressed in people that are having issues with vitamin A.
Yeah. Would you mind just going back to estrogen for a moment? Because do you say estrogen or estrogen? I'm estrogen.
potato, no real whatever.
So I have a lot of clients estrogen dominant. Dare I say I'm even estrogen dominant to some extent because I have a lot of stress in my life too. I do have hypothyroidism. I got a diagnosis when I first arrived in Canada, totally overlooked by Irish doctors. Not to worry though. I've done my best to try address that, but I do think a big factor is estrogen, and I've recognized I take my temperature daily, I monitor my heart rate. Obviously, with what I do, I'm quite aware of my body's whispers, shall we say. At the first half of my cycle, this is just to put it in context for other women, first half of my cycle, my temperature will generally drop. And then post ovulation, my temperature will come back up again. I do use bioidentical progesterone as well in that second half of my cycle. But I just kind of want to elaborate because estrogen dominant, it is so dominant in society. Like it really does have a key factor in suppressing thyroid function, and these problems that women are seeing specifically, I suppose we'll mention with body weight, because that is the hot topic always.
Well, yeah, and I think this is still where the problem becomes multifactorial, because essentially what can be happening here is the estrogen has, and in excess, can have a very catabolic or detrimental effect on the mitochondria. And we know that the mitochondria are essentially the powerhouse of the body, right? They're specifically there for generating energy. Now, to the extent that you're exposed to high levels of estradiol, will suppress thyroid function. Estradiol can damage the electron transport chain. Thyroid, as a rule, tends to stimulate or promote the optimal, best working order of the electron transport chain. So how ATP is produced. So we have ATP, carbon dioxide, and water produced as the end result of mitochondrial oxidative phosphorylation, or how we use our fats and carbohydrates efficiently. Now, with estradiol, it becomes particularly problematic, as I said, when it suppresses thyroid. When thyroid hormone is not there for these cells, they tend to break down. Now, the mitochondria go through these processes, and we have something called that, I think it's been termed the mitochondrial quality control, the MQC. So what will happen is mitochondria, they get damaged, they will either go through fission, fusion, or mitophagy. Now, estradiol will suppress thyroid hormone, particularly T3. So these mitochondria, instead of being either joining with other healthy mitochondria for repair or being degraded via mitophagy, because everyone talks about autophagy and fasting, right? But not everyone talks about the fact that actually autophagy and mitophagy are going on constantly all the time. And to the extent that you have adequate thyroid hormone, will regulate how your cells are functioning, and particularly the mitochondria. Now, an excess of estradiol breaks down this electron transport chain to how you utilize your energy. And that's why, to a degree, cancer has been termed a metabolic disease. The metabolic effects of damage to the mitochondria will keep cells more prone to mutation, which will cause these damage, because you switch from being able to burn fats and carbohydrates in the presence of oxygen with oxidative phosphorylation, and it becomes damaging. To the extent that you lose carbohydrate flexibility, you end up burning fatty acids more as a fuel. Fatty acids produce more lipid peroxides. The extent that damage keeps going on and reoccurring will then dictate that how much you push towards glycolysis. And when you start using glycolysis, which is very wasteful, you waste sugar as an example, will produce more lactate. So this is where we can see why estradiol is particularly problematic from a metabolic disease perspective. And we know from many studies that the excess of estradiol, particularly in the reproductive tissues, the endometrium, fibroids as an example, ovarian fibroids, and also within breast tissues and other tissues, is associated with this estradiol excess. So we have this double whammy effect of estradiol, which can come from our well-known sources. We can get our oral contraceptives, we can get hormone replacement therapies when estradiol is given in excess, to a degree that your diet is high in phytoestrogens, whether you consume lots of beer and wine, you consume lots of soy. These will converge to produce an estradiol excess. And then you converge with the xenoestrogens that we get from all these cleaning products, from all of the flame retardants that act as estrogen sensitizers. They upregulate the estrogen receptor, which can cause proliferation. And so it becomes it's a direct like insult to the mitochondria in the cells and the ability to produce energy that causes this problem. And everyone talks about estrogen dominance. We know from the PMS perspective, because that's most of my clients, so 75% of my clients are female. You see the PMS, you see the aberrant, reproductive tissue issues, whether it's kind of fibroids, endometriosis or cystic breasts as an example. But then we know that within guys, when you're getting gynecomastia, inability to lose body fat, changes to structures where you accumulate more calcium within cells, which is what estradiol causes you to do. You become relatively toxic, cytotoxic, because the calcium creates this exocytability within the cell and makes them very kind of like jumpy, as it were. And so the signaling that comes out of the cells becomes relatively problematic. And you'll get these swelling of the mitochondria, which causes more problems. So it becomes, I think it's really important to recognize the problem of estrogen dominance, but it's only tends to be recognized within this context of what's going on within the reproductive tissues. But again, just like lack of thyroid, it has a very considerable systemic effect on the whole body.
Mm-hmm. Yeah. You mentioned CO2 there. How important is CO2 to not just the thyroid, but the metabolic system overall?
It's very important. I mean, to the extent that it's a key component of optimal energy regulation, i.e. how we utilize fats and carbohydrates within a fuel within fatty acid oxidation or carbohydrate oxidation. If you're not producing enough carbon dioxide, then we can get issues where basically we're not able to process or release oxygen, particularly from hemoglobin, because we can go into a relative state of hypoxia when we don't have enough carbon dioxide around. The Bohr effect, where carbon dioxide levels will increase and cause oxygen to dissociate from hemoglobin. That's maintaining this cycle of optimal energy production. And to the extent we become hypoxic, we will then lose the ability to have this oxidative phosphorylation and then switch towards the lactate glycolytic system, which is wasteful, and it becomes essentially more acidic. The more acidic we get, the more hypoxic we get, the more cell death we get. That's kind of more the end range thing. But you only have to imagine you can only sprint up a hill for so long. Why? Because we produce vast amounts of lactate. Now consider your cells being in a constant state of running uphill because it can't generate energy from this optimal oxidative phosphorylation. This is where carbon dioxide becomes very, very important. So we don't want too much carbon dioxide, but we certainly don't want too little of it. Sometimes I use carbon dioxide as a proxy for thyroid function, because I've seen my fair share of clients that can maintain deep restorative sleep when they use breathing into a paper bag, because they can saturate the tissues with carbon dioxide, thus they can oxygenate the tissues more. And usually they can regulate their blood sugar and sleep a lot better. They won't need to wake up for a pee at night. As your ability to utilize your blood glucose levels is substantially diminished, then you'll start to see kind of waking up at night because you'll be producing more cortisol and adrenaline because you can't regulate your blood sugar levels. And carbon dioxide can just be that step in the right direction, something that's missing for people to regulate blood glucose efficiently and therefore get deep restorative sleep by not upregulating adrenaline and cortisol production.
So would you be encouraging your clients to more so focus on nasal breathing, like Patrick McKeown recommends? Also, within that question, where does low blood oxygen fall into this? If someone has low blood oxygen, would you presume that they actually are utilizing their CO2 more efficiently?
I think anything that encourages slower nose breathing, or at least nose breathing and breathing out through the mouth, or tapes, or bag breathing, or even direct carbon dioxide replacement, it becomes whatever works for the person that they can utilize within their day or before they sleep. I think that the problem with low blood oxygenation is that carbon dioxide can be a key driver of that, for sure. We know that also hyperventilation leads to low oxygen levels, right? So to the extent we're over breathing, will waste carbon dioxide and cause poor dissociation of blood oxygen levels. The other point is that with low thyroid function, we get reduced hematopoiesis, which is basically reduced red blood cell production. So this is where we see low hemoglobin, low hematocrit in some cases, and varying markers with the other red blood cell indices. And that's because if we have reduced thyroid, we have reduced blood marrow or bone marrow production of the red blood cells, which essentially are our key oxygenating tissues, right?
Mm-hmm.
So the reduced capacity to transport oxygen could be a direct effect of having low thyroid function.
But could we assume if somebody did have normal hemoglobin, temperature, heart rate was good, no respiratory issues, breathing is strong and steady, primarily nasal breathing, but blood oxygen is low, we could presume they're utilizing CO2 optimally / adequately?
I'm not too sure on what the exact blood oxygen level would be for that. Are you like from like a PCO2, like pulse oximeter?
Yeah, so an oximeter or even something like a Whoop or the Aura rings will track them, and anything below 85% is considered low blood oxygen. Anything over 95, which is quite a gap, is normal.
Yeah. Yeah, I think that becomes a reasonably variable. If I use myself as an example, I think I got mercury poisoning once, and my SpO2 was consistently around 92, and I would always get altitude sickness when I went above 3,000 meters. So I think for me, certainly having lower levels was not that great, but some people do really, really well with that, and I think this is where the individual variability might come into it a little bit more. But it depends, and I don't have the exact answer to that, to be honest.
Yeah, no, that's okay. It's just something that I was curious about. So, how are you for utilizing different, shall we say, molecules for supporting thyroid? We've already mentioned progesterone. What about aspirin, methylene blue, anything else you like to use to kind of give the thyroid a bit of a kick up the ass and say, let's go?
Yeah, I think any of the uncoupling agents are useful. Aspirin, niacinamide are particularly useful agents, and aspirin, I think, speaks for itself. It's got a long history of benefits. I think some of it's being rubbished a little bit with cardiovascular protectiveness, but I think that just comes down to industry business at heart. So I think niacinamide and aspirin are very well researched and have very optimal benefits, and the benefits of uncoupling, not producing as much ATP and producing a bit more heat, are very beneficial in using more glucose efficiently. I think methylene blue is a wonderful, and people call it a nootropic or whatever you want to call it, an adaptive substance. And I think it was Ray who first introduced me to that idea. I have seen it do some many wonderful things. At its heart, I think its actions are interesting and need to be taken on board subjectively. So, for example, it can increase serotonin because it is a monoamine oxidase inhibitor. But the benefits are it will optimize mitochondrial function. And I think with methylene blue, I think doses used at specific times rather than chronic use for it. I've had some people come to me who've been taking 100 drops a day for 6 months. And they're wondering why their brain feels a bit funny. I mean, again, there needs to be some clarity and some good use of this. Yeah. I think it works wonderfully well as a viral inhibitor. I saw plenty of people that were COVID that I recommended to take it, and it was gone within the space of a day. And again, there are also some implications with methylene blue and thyroid hormones. It seems to increase T3 and T4. I'm not too sure of the actions of that at the moment. Whether it optimizes mitochondria, which we know it does, it stimulates oxidative metabolism. Whether it decreases the need for T4 and T3, and that's why we're seeing more in the blood. It might even stimulate the thyroid to produce thyroid hormone more optimally. But I would say it's a wonderful thing. Low dose for 1 milligram for a long period of time can be very, very useful. I think using it, there are specific things when you can use tens of milligrams for various different things. But I don't think methylene blue is something that needs to be used chronically. I think there might be some validity in some of the neurocognitive deficits for longer term use, but I think methylene blue is one of those things that can be saved for specific things. Yeah. Anything else? I think glycine's a wonderful molecule. I think glycine. Thiamine has its benefits as well. Theanine and glycine seem to be doing some really good things as a combo for deep ways of sleep. But restoring, and I talk about restoring sleep from the fact that if we get better sleep, our thyroid generally works much better, right?
Well, you can
The
see
same.
that straight away. I'm sorry to interrupt. I literally will see that straight away with my clients who take their temperature every morning, and then they'll consistently have poor sleeps for 2 or 3 nights, and the temperature just plummets. And then the next night they prioritize sleep. Oh, I had a great sleep. Temperature's back up again. It's as clear as day.
Yeah, absolutely. I mean, we all know how we don't feel very well from having any gastrointestinal inflammation that would keep us awake by increasing the serotonin and the histamine transmitters. So I think anything that helps to restore sleep is very, very useful. So I think all of the cofactors are useful. Selenium, zinc, magnesium. These are all, particularly magnesium, which tends to be wasted below thyroid function. It can be beneficial for taking that. But I do think when thyroid is optimized, you can start to lose some of these supplements that might not be necessary. I don't think people need to take a magnesium supplement once they have a good diet and their thyroid is optimized. So, there can be other things as well. Now I can't remember anything else offhand for now, but
Taurine.
nutrients.
I really like taurine myself. And when I stopped
Yeah,
taking taurine, because I was like, I'm taking too much, I really noticed a difference when I stopped. And I'm like, I need to bring that back.
yeah, taurine's good. I'm not sure of its effect on thyroid, but we know that it generally, when tissues are damaged or perhaps they're fatigued, that taurine has a very, very beneficial effect. So with anything that can support optimal tissue function, great. I mean, I recommend taurine to several clients. I don't recommend it, but there are key things when I've seen some really good changes where there's a need for it. But sure, yeah, taurine is great. Trying to think what else.
I was primarily using it for the research around it for bile acids and liver function. And I do believe I have liver stagnation. So I noticed a real difference when I stopped taking it. And that goes back
Yep.
to chicken or egg, liver or thyroid.
Yeah, and cholestasis, which is kind of the sluggish gallbladder, right, is very much thyroid mediated. Is that you just don't process the bile, the bile duct doesn't optimally work. You don't the utilization of bile acids, they're not kind of very functional when thyroid is low. So gallbladder disease, gallbladder stones are very much implicated in low thyroid function. It does become first what came first, the chicken or the egg. But then again, you're absolutely right. Taurine can have a very positive effect on some people there without needing to take thyroid as well. So yeah.
I know we're coming close on time. If you don't mind, I was sent 3 questions on Instagram for you from some of your fans.
Okay, sure.
Okay. So the first one was question, is thyroid therapy for life? So once I think she was asking, like, once you start taking thyroid and you notice the improvements, are you on it for life or you're going to regress again?
No, it really does depend. And I think that might depend on a number of factors, such as inheritable traits, environment that you live in, all of these kind of components. But to the extent that when you stop, and it's never a good idea to be taking a high dose of thyroid and then stop, because within 2 weeks you will kind of come crashing down to a degree.
Mhm.
But generally, that's if there's generally been a good need for you taking that amount. But generally, as a rule of thumb, the thyroid gland will start producing thyroid again. It's not like you're going to stop. You don't suppress it forever. The thyroid function is still there. It has blood supply. It has nerve stimulation. There's signaling going on at every level. So as you start to become deficient in thyroid, TSH will eventually kickstart the thyroid to work. Now, I think TSH should be kept at a very low level because we want to keep TSH within a range where it isn't promoting kind of inflammation and fibrosis. So yeah, I think you can stop it. I've seen people that have stopped it and done very, very well. Some people who don't do that well and can need taking it. But again, to the extent you could argue these days that animals are becoming more hypothyroid, and muscle meats will contain thyroid hormone because we know that within the cells there is a reasonable amount of thyroid hormone. So it depends. It comes back to that point. It depends. Some people do really well on a glandular. Some people do really well on a synthetic thyroid plus Cytomel. Some people do really well on an NDT, and that's some people do really well when they stop those. Some people don't. So the answer is that no, not necessarily, but it depends on the person.
One thing we can actually get here, if you look hard enough, we can get bovine thyroid gland.
Right.
Um,
Okay.
so, but I think from my experience, higher dosages are needed. So a week on low and then slowly titrate up to see how you feel. The thing
Yeah.
with
I mean,
natural,
sorry.
sorry,
Go on.
I was gonna say the thing with natural is unlike synthetics, we can't be sure of the exact amount we're getting in it, whereas with synthetics we can.
Yeah, and some people, you would get a number of people, and I was like this many moons ago when I kind of was in my holistic lifestyle coaching and nutrition as a personal trainer, is that I saw everything that was not natural as being problematic, and we know that the synthetic thyroid, it's structurally the same and works the same as normal thyroid hormone. So I think it's worth considering that some of the best results I've seen. I take generally as a rule of thumb these days is Cytomel T3, and generally I do pretty good on it. So I think understanding that the synthetic form is safe, effective, and you can get the dose pretty much right. NDT, you can be a little bit wayward with that still. It's not always guaranteed. You can get good pharmaceutical compounds of it, or it's compounded NDT, so that it's at the right dose. And I think generally before the NDT was really good quality. In a lot of places now, it really has dropped off a cliff on the terms of quality.
Yeah, and expensive too, especially if you're titrating up. It's super expensive. So
Yeah.
we had already addressed the second question was, should you jump straight into supplementation? No, nutrition and sleep first before looking at other stuff. The third question then was for somebody who has tried everything and taken Synthroid, I believe, 250 micrograms, and seen no change in weight loss, still has systemic inflammation, is now considering Ozempic, which we had mentioned before we recorded. What would you do in a situation like that with a client where, from your perspective, they're doing everything right? The aspirin, the progesterone, the sleep. I know there's a huge amount of stress and inflammation. Um, would you increase thyroid? I know it's only Synthroid. Bring in T3, except it's hard to get T3 in Canada, and I'm not exaggerating. It's very hard to get T3 in Canada.
Yeah, I mean, that's the difficult one based on the geography and the authoritarianism of the country you live in. But I think this is where you probably, even my advice would, if that was a client of mine, I'd be going like dropping down to 100 micrograms of T4 and then starting off with something like around about 10 micrograms of T3 and increasing, or even lower than that. I mean, 5 or 6 would be ideal, but you'd probably find a 4-to-1 ratio of T4 to T3 would do that person the world good. And then there might be a need to increase from that. Obviously, I'm not a doctor. This is based on suggestions from my own thought processes. You would want to go and check up with your doctor if you felt so inclined. So I would say that increasing the T3, if you're at 250 micrograms of T4, you're not converting T4 to T3. I'm sorry, or you're just going to be overwhelming the system with T4. And I think that's just a case of it's not working, let's add some more. It's not working, let's add some more. I mean, where do you keep going with that? It depends on, I think you have to look at the markers though. If the person is just looking at weight as an example, I mean, there can be many reasons why you can take thyroid hormone and not lose weight, right? It's not going to be the be all and end all. People still have to, whether it's calorie deficit, whether it's kind of there are other hormonal deficits, maybe there's not enough testosterone, progesterone, maybe there's an excess of estradiol. It could be that T3 is needed here, but it does make some sense to look at perhaps what's going on with cholesterol, what's going on with glucose, what are the red blood cell indices looking at, what's prolactin doing. All of these things that we've talked about so far can be beneficial. And, if it is that, Ozempic or whatever it is, that's the thing, is that you're still missing the point that something's missing there. and going on a GLP is not going to correct the deficit. And my skepticism with this at the moment, I know there's some wonderful research out there at the moment, but as we know with research, there always is wonderful research to start with. And it's not until often, sometimes decades later, when you start to see what's going on from the very negative research. But we've seen that with statins. We saw that the Jupiter study was flawed when they brought it in as primary care intervention. We know that there are issues with statins because they cause diabetes in a large amount of people who take chronically. With the Ozempic, I think I'm not an expert on it from the small studies I've looked at, or there are some meta-analysis that suggest that the longer studies, I'm talking over 100 weeks or so, there is an increased suggestion of links with thyroid cancer. That's not come out in all of the studies, but again, the meta-analysis that I've seen that suggested it is relevant is looked at the association between studies that are going on a lot longer rather than the shorter studies. So we need to be mindful that, again, it's a shortcut, not correcting any deficit into the low carbohydrate diet. You're removing the substrate with a low carb diet, but you're not actually addressing the glucose utilizing mechanism. So I think there will be problems with that. And do you know what? If somebody wants to use that, not for me to judge, and they get results of that. For some people, losing weight is their key goal in life, right? And looking thinner. And if that's what you want to do, you can't argue with that. But again, there may be ramifications with this further down the line.
Just before I let you go, so with this specific lady, she's already in a calorie deficit, sometimes 1,100 calories a day. She's sleeping, so I believe she used to only sleep 3.5 hours. Now she sleeps almost 8 hours. So there's been an improvement. I believe it's inflammation and stress is preventing her from converting. My concern with using Ozempic, again, I would support her if she decides this is what she wants to do. But my concern is that if the metabolism is already this slow, which indicates that the thyroid function is slow, now we bring in something that's going to suppress hunger and satiety even more. So we're going to potentially put you in a bigger calorie deficit, which further deprives the thyroid and metabolism. Now we're potentially slowing the thyroid even more. And we just see this negative downhill slide happening. Like, that's my concern, because I know she's not weightlifting for one. So we're not trying to preserve muscle mass there. We could potentially increase the protein, which would be great, but I'm still concerned that if we put her in too much of a calorie deficit, which is what Ozempic will do, then we're going to further exacerbate the problems that she's already having.
Yeah, I mean, this going back to your question about reverse T3 is that we know chronic calorie restriction will suppress T3. So you could probably be taking quite large amounts of T4. But if your body is in a calorie restricted state, T3 is suppressed. It's a well-known subsequent factor of calorie restriction and fasting. So you will probably be producing quite a lot of reverse T3, because the body doesn't like ramping up energy metabolism when it's in a calorie restricted or deficit state. So it's a fallback survival mechanism to suppress T3. So this is where perhaps T3 could be good. But again, this is where you would want to look at the other markers to get a better idea, I think. So, but yeah, what's the glucose doing? What's the cholesterol doing? All of these factors as well. Be interesting to see if she ever does get on T3, what happens.
Yeah. Well, thank you for this, Keith. It's been fascinating. You're a gem. Where can people find you? You got your website. Yeah, I follow you on Instagram, as you know.
Yeah, that's generally it. I'll be on Instagram under Tomo Littlewood, I think. Website's Balanced Body Mind or keithlittlewood.co.uk. That's generally it, to be honest. I think I have a page on Facebook that I haven't updated for a number of years, but yeah, that's pretty much it. I'm on Twitter as well as Balanced BM.
Yeah, I have a love-hate relationship with Twitter. It annoys me, but I feel like I should post, but it annoys me.
Yeah, I have the same thing. And to be honest, sometimes you're just so busy. It's just like what I really enjoyed doing for a number of years was talking about Ray's stuff and hormone stuff and posting on Instagram. I'm just trying to bring a bit more back into that now, because you get so sidetracked with research. And I quite like going back to Ray's work because it grounds me substantially when I'm staring down a microscope or looking what some metabolism of a cell is doing. So yeah.
I really like your Instagram page. So people, you can look him up under Tomo Littlewood on Instagram. You got some great posts there. So if there's, you explain things really great, like your thyroid the other day, you had a thyroid video and vitamin D, and then there was another on vitamin A as well. So thanks for everything you do. And thank you for your time. This has been awesome.
Thanks for having me. Great to have a chat.
Thank you.